manage their patient's humidifier, the temperature based on what their secretions are like. One thing I want to mention to you, and I know that I've gone over my time just a little bit, when you're managing someone with a active heated humidification system in the room, I think it's important to note that most of the babies that we take care of are receiving some form of extrinsic heat in a radiant warmer, or they could be being heated with an isolette. Keep in mind that if your temperature probe is anywhere in the proximity of that system, there's potential that the humidifier will get that signal and it will say, oh, I'm doing a very nice job at humidifying or heating these gases. Maybe I should back down a little bit. And in doing so, you're going to drop the absolute humidity of the circuit. So that patient is going to get a drier gas. So what I suggest is if you have babies that are in an isolette, take the temperature probe, put it outside of the isolette. If you have babies that are under radiant warmers, take a little cloth or take a little EKG lead, the sticky EKG lead, put it on top of the temperature probe, and there'll be less interaction with the radiant warmer isolette with your temperature, with your humidifier. But also keep that temperature probe sitting straight up in the air. Because if it's bent down like that and there's water pooling on that temperature probe, that will heat up. And it will also send a signal back to the humidifier to reduce the temperature. So keep in mind that high minute ventilations, increased respiratory requirements of your patient, may require moving from a passive to an active device. Keep them clean. Make sure that you wash your humidifiers and have a solid approach in place for washing them and trying to sterilize them. But again, remember, humidity doesn't, or humidified gases don't really contribute to infection. I'm going to just move forward. For those of you that are interested in this paper, I could provide this to you if I have an email address. This is a brand new paper that was published in 2012, and it's an American Association of Respiratory Care clinical practice guideline, and it goes over just about every aspect of humidification management for your patients. And I think there's many pearls that you can take away with this. Each one of them are based on grading the quality of the experimental data. So that's something that I think will be very helpful for you. In closing, I want to show you one experiment that we just completed. This is an experiment that we conducted in my laboratory because we work a lot with bubble CPAP, bubble continuous positive airway pressure. And we were touring through the neonatal intensive care unit of one institution, and we found that the babies that were being supported with bubble CPAP, there was a lot of cool air moving through this neonatal intensive care unit, and we found that there was water building in the expiratory limb of the circuit. Okay, these systems typically have a heated wire during inhalation, but on exhalation, there's no heated wire. So the gases that are coming out of the lung and the gases that are coming through the system come in contact with this cool barrier and they rain out. And we looked at the babies and they were working really hard, and I grabbed one of the respiratory therapists and I said, your baby is bradycardic and their saturations are low, and could you come and look? And they emptied the water and it went away. And I'm like, okay, is it possible that there's a bolus of water in there that's kind of creating a choke point and causing these babies to have higher CPAP than what we really think we're delivering to them? So we went on and got a little bit of funding and conducted a study, and these data will be published this year in the Respiratory Care Journal. What we did is we ran a humidifier, attached the humidifier to a bubble nasal CPAP system, and had a test lung that was breathing spontaneously. You'll see that test lung later. The test lung was breathing spontaneously in and out, and we measured the rate of fluid condensation that was occurring in this expiratory limb. So in the gravity-dependent section of this expiratory limb, fluid built up, and within 2 or 3 hours, if you didn't pay attention to the fluid that was in there, at a rate of about 3 mLs per hour, the fluid would increase. And what we found in these systems, and this is the condensation volume right here, at different flow rates, and this is the tracheal pressure, in as few as 3 hours, the volume that was contained in the expiratory limb of the circuit caused the CPAP in the test lung to be twice as high as what we had it set at. And I know that all across India right now, many of you are entertaining the idea of bubble CPAP, and I think it's a wonderful thing. But also keep in mind that you don't have alarms on the system. you may not be measuring pressure at the proximal airway. All right, and by avoiding those very well-needed safety features, you run the risk of this happening, water building up in the circuit. If you don't have those features available to you, just make sure that you're checking that circuit every hour and eliminating the fluid from that system, because humidifiers are here to help us, but in some ways, as we've learned today, they may harm us. So that's it for my presentation. Thank you.
Thank you.